So if you don't mind, if we can wait for another few minutes, because I believe the MMC lot is trying to come in, but they have some connectivity issue, the orthopedics department. So if we can wait for a few minutes.
Yeah, sure, madam. Sure, madam. Just let us know when we are ready. So, Denny, how is the corona issue there? When I was there 2 weeks back, everything seemed normal, except that when you went to the malls, you need to have
So Dr. Raj, things are about as normal as we can get. The only time masks is advised to be worn is in the hospitals, and that being the only thing. Public transport is also recommended, but otherwise, everyone's quite easy about it. In fact, many of us are saying, why we don't mind getting it, that will boost our immunity, because most of us are double boosted, so 4 times already. And if anything, the symptoms are quite mild. I actually just came back from the UK, and the first day I had a bit of fever, so I thought, that's it, I would get it. I'm still negative. I don't mind getting it. Because the variant is, I think genetically, human beings are coping with it. We're learning the immunology of it. So with multiple boosters, we are quite, if anything, the symptoms are mild.
Same here. But after I came back from Singapore, I had fever for 4 days. They said it's the Singapore flu. I didn't know what it was like, but it was also mild and just.
But you're all negative, right?
Yeah, we're all negative. Yeah.
That's the thing. So, just because there's COVID doesn't mean simple flu doesn't exist, no? So sometimes it could be that. And with a bit of confidence, I think life begins to come back as normal. You start traveling, and I think that'll be nice. And I'm sure in India, travel has more or less resumed.
It's not resumed. It has got a rebound phenomenon.
Okay. So I'm sure air travel
people are looking
rebound.
Out for all flights are full. So we got a message from BC Madam that we can start. So, Madam, would you like to give a start, Madam, or?
So you can start, sir. You can start, because our people have joined and some of them are on YouTube. They are switching out. So you can start, sir.
Thank you very much, ma'am. And I will begin with the first
talk. I would like to start off by thanking our Vice Chancellor, Madam, and the University of Madras for this very innovative and very novel program. And it's a real pleasure that to start off the series of this with Singapore General Hospital, we have really a star with us to kick off as the opening batsman for the series. And thank you, Dr. Professor Denny Lee, for being with us. Thank you for your time. Most of you in orthopedics would already know Professor Denny Lee, but I would have the honor and privilege of introducing him. He's currently a senior consultant in the Department of Orthopedic Surgery, Singapore General Hospital, subspecializing in sports and shoulder surgery, which is actually, I can say, is the in thing in orthopedics now. Most of our residents, they all have an aspiration to be sports medicine specialists. So I'm sure that there is a huge audience for him today. In 2001 to 3, he spent 2 years doing fundamental research at the Imperial College of London on the anterior cruciate ligament. And thereafter also had a year during clinical fellowship in shoulder surgery in Zurich and later in Boston Howard University. Subsequently, he has been involved very actively in clinical work, academics, and research. He has a lot of professional leadership activities, and he has been the president of the ASEAN Society of Sports and Arthroscopy. And also he is the founding chairman of the Shoulder and Elbow Society in Singapore, which he started in 2017. He is currently the vice president of the Singapore Orthopedic Association and will also be the organizing chairman for the Asian Shoulder Society meeting in Singapore. His academic and research activities not limited to Singapore alone and spans over many countries and universities. notably the Duke University, Indonesia, Vietnam, Myanmar, China, and India. He has membership in numerous professional and academic societies and also has got a host of publications in peer-reviewed international journals. So thank you, Dr. Denny, for being with us. We are really privileged. Today he's going to talk about two interesting topics. The first one is also something a very burning and very interesting current interest topic for every orthopedic surgeon, and that is on yearly cartilage injuries, cartilage ulcers, and yearly knee osteoarthritis. Following that, he will also talk about the role of acellular hyaluronic acid scaffold, the surgical outcomes of it and outcomes. And the third topic will be about the arthroscopic cuff repair augmented with autologous PRP. So all these three topics are currently have high interest amongst orthopedic surgeons, and I'm sure that this is going to be a very, very interesting session. So thank you, Dr. Lee, and may I request you to go on with your first. Thank you.
Thank you, Dr. Raja, and good afternoon to all listening in India, my friends in the audience. Namaste. Thank you very much once again for inviting us. So as what Dr. Raja said, I sort of focusing on biologics in sports surgery. And since most of our cases are overwhelmingly in the knee, so I thought the first two talks, I'll focus on the knee, and then perhaps the third one will do biologics in cuff repair. And so the first talk really is about cartilage ulcers, early knee OA, algorithm and approach to these lesions, what we can do as surgeons. And essentially, that's quite a lot. Yeah. So, yeah. So once again, thank you for your kind invitation. So Singapore, we are open and we welcome all our friends and visitors to come here. As many of you have been to our country, this is our bayfront. That's Raffles Hotel, yeah, where the famous drink comes from. That's our national flower. And this is the Malayan, the icon of Singapore. And as you know, that Singapore is a melting pot of all our cultures. So there's Indian culture, Chinese, Malay, as well as the other mixed races. And like in India, we too enjoy our food. There's chicken rice, satay, and seafood, yeah? So come, I think travel is open, so we welcome one and all. This is where I practice at Singapore General Hospital. And some of you may know that it was started as a British Army hospital way back in 1821 and has changed so much since then. Yeah, and now we are the largest concentration of medical services with more than 5 national centers. It's sometimes it's a bit too big, Dr. Raj. From my clinic to my office is about 1.5K, so it's a little bit challenging. We have more than 1,005 beds, small compared to India, but large in our country, with 5 national centers and that amount of clinical load. We are heavily invested in research and education with Dukes and with other centers. So today, I want to start off with the idea of cartilage injuries. We'll review a little bit what cartilage is like, then the options, what is available to us as surgeons. Okay, and then in the second talk, I will focus on this acellular patch, which is really the hottest thing. So let's review a little bit about cartilage. These are slides that I usually share with our residents. So those experienced surgeons conversant in this, please forgive me, we're going over the basics. So for the residents, this is probably the essentials in human articular cartilage. Remember, it's made of the chondrocytes, less than 10% by volume. The rest of the organic matrix is really type 2 collagen fibers, around about 30% by weight, and then proteoglycans. But a large proportion of the cartilage is actually water, about 70, 80%, with inorganic salts and other matrix proteins. Then when you cut the cartilage during knee surgery, it looks really like a homogeneous yellowish layer, but it is not. It is very heterogeneous. It is complex, more than 4 layers. So in zone 1, the cells are discoid, the fibers are parallel, and they're meant to resist shear forces at the top. In zone 2, it's a transition. And then in zone 3, the fibers are perpendicular. And it is zone 3 that resists compression onto the cartilage. Whereupon at zone 4, it anchors the entire cartilage to the bone. And it is in zone 3 that negatively charged glucose aminoglycans with cations like sodium create this huge water resistance, the Donan osmotic effect, up to 0.35 megapascals. And this swelling is then compensated or balanced by the tension of the collagen network. So it's a very nice, compact, fluid-filled cushion. Yeah, its mechanics is a little bit more complex than what we think. But it's very exciting. And it is this region that we will now look at. Now, cartilage ulcers in our patients, actually, most of them present quite insidiously. Athletes and military people tell me after a long run, the pain is rather more of an aching sort of pain. It's not a sharp pain, it's not instability, it's just an aching pain, which, perhaps when we were young, we brush it off, but hey, it gets worse and worse. When we do x-rays in these patients, usually it's negative, and we do it just to rule out obvious fractures, osteochondritis dissecans. It's the MRI that provides the first clue. The MRI shows edema of the subchondral bone. The MRI shows loss of cartilage, as shown in this example. Of course, the gold standard for diagnostic and therapeutics would be the arthroscopy. So I use the outer bridge classification, which describes the severity of the cartilage. 0 being normal, then 1 is the cartilage is softened and swollen. Yeah, that's what chondromalacia really means, swelling of the cartilage. In stage 2 of the outer bridge classification, there is fissuring. Stage 3, there's fragmentation. And then 4, all the way down, erosion to the bone. The ICRS is useful for studies and research and paper writing, but not in daily use. So what can we do? Actually, the plethora of options is immense. Easily, there are about 5 non-surgical and 5 surgical things. So if the patient comes in with acute pain, of course, we can give painkillers, that's one. Then you can try supplements, glucosamine and supplements. Some people don't believe in it because we tend to overpromise glucosamine. People say that glucosamines can heal. They don't. They reduce the symptoms. Yeah, but it is part of our armamentarium. So supplements, 2. 3, physiotherapy, weight loss, lifestyle modification, modifying the way we do sports, the way we jump, the way we run. All this will help with the pain and the progression of cartilage loss. 3, bracing. Bracing is particularly useful in patella pain as well as medial or varus knees. And then finally, injections, either hyaluronic acid, platelet-rich plasma, and some patients still receive steroids, although we're moving away from steroid injections for OA. So easily 5 non-surgical options. What about surgery? Well, there's one cleaning up, simple cleaning up, microfracture, OATS or mosaic-plasty, which is osteochondral autograft transplant. Then there's cartilage transplant. And finally, the second talk that I'll be talking to you about, the acellular patch repair. No cells, just the scaffold. Each of these procedures I will go through with you in the discussion after this. Okay, so bear in mind, roughly 5 non-surgical options and easily 5 surgical options. Let's take a look at them. So how I approach an ulcer, critically, I look at 3 main things. Size of the lesion, that drives everything. Yeah, less than 2 to 4, or greater than 4 cm square. 2, containment of the defect. Is there a nice rim of cartilage in the ulcer? Because if there is, then our options are different compared to if it's an uncontained defect. And the third thing is the state of the subchondral bone. Yeah, that determines what we want to do. Location of the defect is plus minus. And if you notice, age is not really my criteria. Yeah, although we know that senescence of the cartilage and the chondrocytes is an issue. So 3 main criteria, how do I fit them into an algorithm? This is how I do it. So anything small, less than 2 cm square. Usually microfracture will do the job, whether it's contained or not. And if the subchondral bone is soft, then maybe we do mosaic plasty. The mid-sized ones, 2 to 4 cm, that's the most common one that we deal with. So if it's a contained defect, in the past we used to do cartilage transplant, but nowadays we do patch repairs. Yeah, acellular, but just a scaffold, we put it over. If it's uncontained, we still can do patches or just microfracture. And if anything has poor subchondral bone, then we need to use the oats as an option. And finally, large ulcers like more than 4 cm. If it's a contained defect, again, we can use patches. If it's large, mega oats, or if it's uncontained defect, just microfracture. So we'll now look at each of these in case example. Yeah, and why some of these options are useful and some are not. So some case examples. Let's say case study 1. So this was a 39-year-old IT consultant, right knee pain, 6 months prior, and no locking, no instability, but as you can see from the X-ray, rather there's medial joint line tenderness with the patella grind positive. As you can see from the X-ray, clearly it's in varus, with loss of cartilage on the medial side, which is the classical OA. MRI shows tears of the posterior horn of the medial meniscus and an MFC ulcer of 2 cm or more. If it's in more X-rays on the long leg films would show clearly a varus deformity. And this is quite common in some of our presentation. If you look at then, you summarize it. It is small, yeah, it is a contained defect, and it probably has good subchondral bone. So by right, it is easy, and we apply all our options. Most of them should be able to answer that. The problem is the varus deformity derails most of these options. This case illustrates that no matter what we do, if the mechanics of the lower limb is not well taken care of, most of these biological options will not work. So that's the first learning point. Biology needs proper mechanics for it to succeed. Yeah, so that's why I put this as the first case. Let us be mindful of the mechanics, make sure that it is well corrected before we offer the biologics. So in this patient, what we did was an osteotomy, an opening wedge osteotomy to correct that alignment first. And then the biologics will be our second stage. Okay, so now let's look at case 2. That is the first learning point, mechanics before biologics. So this is a 50-year-old lady known to have generalized OA of the knee, and she presented with left knee pain for about 4 months duration now. Again, medial joint line tenderness, and she remembered it after a particularly bad swing during golf. The examination shows 120, medial joint line, and plus minus grinding tests. But if we see the MRI, there's medial and patellofemoral severe OA with full thickness cartilage loss. It's quite widespread. There's a large medial meniscus tear and a sprain of MCL. So again, we apply our criteria. It's a very large tear. It's an uncontained defect. And probably because of the chronicity of the pain, to some extent, maybe the subchondral bone is affected. So what can we do? Oats, transplant, patches, really in such uncontained defects, is only microfracture, or we wait upon age and worsening of the cartilage, then maybe total knee. But at 50, still active in golf, I don't think I would do total knee yet. Yeah, so it's really microfracture. Microfracture, as those of you who are doing it, we know that it is really to create holes about 2 to 3 mm apart into the subchondral bone. these holes should not merge, otherwise a microfracture becomes a macrofracture. So the defect fills up with fibrin clot, which over time becomes fibrocartilage, not hyaline cartilage. So best results are seen in those less than 2 cm square. So in here, schematically, we do the microfracture, but of late I've switched to micro drilling. I use 1.6 mm drill perpendicular to the surface, and then I go slightly deeper than that. Yeah, until you can see the fats coming out. So micro drilling, well spaced out, for me works well. So let's look at case 3. So this is a young chap, 27-year-old chap, recreational soccer player, right knee pain, 2 years. X-ray looks very nice. Examination, full ROM, otherwise very stable. All the provocative tests are negative. But when we see the MRI, there is an osteochondral defect in the lateral femoral condyle, 1.4 by 1.8. So it's quite small, but it's well. So we look at the criteria. It's a small defect. It is well contained with good subchondral bone. So these kind of lesions are okay for microfracture, or if you want to do an acellular patch repair. Yeah, so we patch it and lay it over. So this is the arthroscopic patch repair using the hyalofast, which I will present in my second talk. And here we see the micro drilling, same thing happening. And once we do an air arthrogram, we dry it up, then we place that patch right over it. So these are just summarized videos, and I'll show you step by step in a while. Yeah, once it's filled with blood like that, it's very nicely in place. All right, now let's look at a slightly different one. So we've seen large defects, we have seen small, well-contained defects, we've seen poor mechanical alignment. Now, what if we have all the same factors, but the subchondral bone is weak or poor? This was a 24-year-old female, right knee pain of more than a year's duration. Medial-sided, no trauma, has difficulty. Examination was remarkably normal, and so were the x-rays. But when you look at the MRI, there's a grade 4 osteochondral lesion right over the medial sulcus of the femoral trochlea. She, in fact, had undergone right knee arthroscopy some time back by someone else who found cartilage thinning but could not find that defect. And in fact, the symptoms persisted thereafter. Yeah? So persistent osteochondral defect, poor subchondral bone. When we look at it, small defect, well contained, but poor subchondral bone. Really, at this stage, we really need to do OATS, mosaicplasty, or osteochondral autograft transplant. We need to address the subchondral bone. And this can be done arthroscopically. OATS, as we know, is to use osteochondral plugs that can be taken from a non-weight bearing area, right transposed or transplanted in the same knee to the weight bearing zones. Yeah. So arthroscopic mosaicplasty, this is what we do. So with the camera looking, I probe the entire cartilage. I use a needle probing the entire cartilage, and sooner or later you'll find a defect. Roughly, geographically, you match it with the MRI. Once you see the defect, you find that the whole thing caves in. The entire cartilage is like a carpet over a hole. It just sinks in like that. You know? So then you know that's where the osteochondral defect is. That's what you need to address. We need to plug that hole up. And you cannot just use another carpet. You need to fill it up with a bone plug. So I clean the defect, yeah, and I roughen it, I size it, and I core out so that it's ready to receive a nice peg. We then go to the non-weight bearing zones, which is usually right at the periphery, and I harvest an osteochondral plug of that same size. We then bring it back into the plug and plug it in. So we use the patient's own osteochondral plug, and really to impact into that hole. We must make sure that the entire impaction is perpendicular to the surface. Otherwise, you can break that bone plug. And be careful because you do not want to damage the cartilage. Yeah? So this goes in slowly but gently. Well, there you have it. This osteochondral plug. It's a mosaic plastic. It's called mosaic because we can do a large defect. It can plug in many holes. Yeah, but in this case, I only needed one. So that's nice. And she went on to do well. And then, of course, finally, option 5 is a transplant, which what we do is we harvest a small amount of cartilage, about 200 to 300 grams, and then enzymatically digest, isolating the chondrocyte, which is then grown in the lab over 6 weeks. It's then implanted in. So schematically, it used to be done and as an open surgery where you use the little periosteum to cover it. But this surgery is quite tedious. So this is the first generation using liquid transplant. 8 years ago, we shifted to a gel-like transplant, where the liquid transplant cells and the gel is mixed. Yeah, and then we straight away just gel up the entire defect. This is we moved away from this as well. So there you have it, the 5 different options. Remember, these are the contraindications to biologics: infections, severe inflammation, mechanical alignment, malignancies, and medical problems. But our algorithm, our approach to ulcers, we are driven by size of the lesion, containment of the defect, the state of the subchondral bone. And our options that we can fulfill it, apart from the non-surgical things, the surgical options are simple chondroplasty, microfracture, oats, cartilage transplant, as well as the acellular patches that I will talk about. Yeah. So in early OA, cartilage ulcers, whenever we see them in arthroscopy, actually there are many things we can do, and this is what I've shared with you. Yeah. This again is my. And with this, I thank you very much. We can take questions at this point, or I can go on to the second one, which is focusing on the hyalofast, the acellular patches, which is the current trend nowadays. So thank you, Dr. Rajan.
So, Denny, thank you very much for a very, very comprehensive and very lucid talk. Just before we go on to the acellular patch, if I can just ask you a couple of questions.
Sure.
So you said very clearly, I mean, you're bringing in mechanics. Can I request everybody to be muted? Everybody else, please. Because there is a lot of Mr. Nitish Khanna. Can you mute your... Okay, thank you. And I would also like to welcome one of our very prominent arthroscopists and shoulder surgeon, Dr. Ram Chidambaram. Welcome, Ram. So going back to the discussion, you said you were not taking age into consideration at all. And but certainly there should be a higher limit of age that comes into your consideration when you do this.
So the reason why I say that, because we've seen where a 60-year-old lady comes in with a small, well-contained defect. So I'm not resistant to treating it as a well-contained defect and therefore patching it out. That's what I mean. But chances are when a patient comes in the 60s, chances are it falls into the large uncontained defect, meaning it's a widespread tri-compartmental OA, which I don't think biologics is an answer. You know, so I don't want to categorically say, oh, you're 60, you just need a total knee. Yeah, so, but the differentiation about the quality of the cartilage at that age, we don't do that clinically. So it's still driven by the size of the cartilage, the containment. And I'll show you later on where we have a 70-year-old with a contained defect, but we managed to patch it up. Then what I did with my Hyalofast series, I peg it against age. Does age have a barrier or worsening effect? And not really. It's really the same factors we spoke about: size of the defect, and as well as the bone beneath. Yeah, but I agree. The chances are, yeah. Go ahead, Dr. Raj.
So in all these cases, I know there are many residents also watching this. For that benefit also, I would ask. So your assessment is purely by MRI, or would you sometimes do preliminary arthroscopy before you decide on what you're going to do?
Okay. The moment we've been put in all the symptoms and the MRI, when I do the scope, usually it's a little bit more than diagnostic. I would be prepared to at least do a patch. That being the least, as it were, it's a very minimal invasive thing. It does not have long-term consequences, I mean, downstream or side effects. So I won't be committed to, say, a transplant or a oats so early. But a patch can be done easily, a patch with a microfracture. So that can be done quite easily.
Do you have an upper limit of obesity or osteoporosis for all these different?
Yeah.
Because when we talk of mechanics, then obesity is a overriding biomechanical factor.
Yeah, that's a really good point, because my feeling is that the quality of the bone, not just the quality of the cartilage, the subchondral bone is as critical. But at the moment, we haven't worked out, because we have started doing subchondral plasty injections, but to strengthen subchondral bone. And we think that it is going to be important, but we haven't factored it in, we haven't worked it out yet. Obesity will affect alignment and overall, so that comes in under the mechanics of the alignment, yeah, which we think will be important.
Thank you. Ram, do you have anything to add?
Hi, welcome, Devi.
Hi, hey Ram, hi. Good to see you.
Good to see you here. Very clear presentation. Now, I would like to ask, what is the role of a concentric arthritis? We're not talking about localized osteochondritis, but a generalized arthritis, moderate, no mechanical problem. Do you consider biology? Do you consider PRP injection as a standalone treatment or stem cell? And what is your take on it?
Yeah, so if it's generalized and relatively asymptomatic, so sometimes we just go ahead with PRP and hyaluronic acid run. So as an injection, when we think about injections, more than just hyaluronic acid or PRP, I use them together. So right. HA is a very nice carrier for PRPs, whether it's a single or triple, but they have really nice results. But we really have to be careful of the mechanics. Yeah, but if it's generalized, non-contained, I don't think biologics or minimally invasive has good results. I mean, at most about 50-60% relief, so we can't overpromise. But HA injection with PRP, really, that's okay to tide over the symptoms.
Would you give that concurrently or at a spaced interval?
So we do it at the same time.
Same time.
So there are two ways to do it. Either you will spin PRP and then HA at the same time, but I always give HA first, which is a carrier, and then the PRP. There are new mixtures where we can mix them at the same time. And so the HA is spun in the centrifuge as well. That's a bit neater because then everything goes in.
Thank you.
Yeah.
Thank you.
Thanks, Ram.
Thank you.
There is a question in the Q&A that I think Dr. Krishanu asks, how do you address grade 3-4 defects in non-weight bearing regions? In general, if it's asymptomatic or relatively asymptomatic, I may not do anything to them surgically. But if it's a well-contained defect, usually the cartilage in the neighboring weight-bearing zones is a little bit unhealthy too. Yeah, so because if it's a non-weight-bearing zone that has a cartilage defect, then there must be a cause. It tend to be, for example, in the trochlea, where there's a braiding by the patella or something has happened. If there's really no trauma cause, then we are worried about other things like osteochondritis dissecans or something else. Yeah. But in general, I may not patch them if it's really asymptomatic, non-weight bearing.
So, Siddiq has raised a hand. He's my fellow. Yes, Siddiq.
Good afternoon, sir.
Hi, good afternoon, Siddiq.
Sir, my question is, why are we still persisting with microfracture when we know that it is going to produce fibrocartilage and the result is going to deteriorate over the period of 1 or 2 years? Then why we are still persisting with microfracture? Why are not we changing to any other techniques?
Okay, great question. Thank you. Microfracture is very useful in small tears, Siddiq. 1 or 2 cm square. I think it has excellent results. But I agree with you that if it's more than 2, the results are not favorable. Unless you can't do anything more, like uncontained defect, then I will have, that's really a no choice thing. But if I have choices, well-contained defect, more than 2, I will not do microfracture alone. I will do it with other things. Yeah, but if it's very small, then microfracture is particularly useful or can still be useful. And it's true, it does produce fibro cartilage, or not hyaline cartilage. But if it's enough to tide over the symptoms, to ease over the pain, then that's good enough for me. Yeah, so it still has its role.
Yeah. So maybe we should now go on to the next topic of acellular hyaluronic acid scaffolds.
Yep.
Which
Okay.
I think should be a very interesting concept.
All right. So thank you very much for the questions. From all the options that we discussed, now I'm going to focus on the acellular patches. Part of the journey that I came to this was because I was doing cartilage transplants, which is the option number 4 in the previous talk. But cartilage transplants are just so expensive, and it takes 6 weeks. So that's when we begin to question, what if we take away the cells and just use the medium, the matrix? Will it be good enough? Yeah. And instead of multiplying the cells, I will do a very good microfracture or micro drill so that it's effectively like a BMAC. Yeah. And then all I apply is a scaffold, acellular scaffold. Will that help? So this is what I wanted to share with you. So over the years, we are using this. All this we have seen in the previous talk, all the options, the criteria. So Hyalofast, what is it actually? Hyalofast is a biodegradable and bioactive hyaluronic-based polymer. It is crystallized into a scaffold for a one-step repair. So it's for both chondral and osteochondral stage 3 to 4 by ICRS classification. So it can be used as a scaffold or as a chondroprotective coverage. So most of the time I use it as a scaffold. Why hyaluron? It is a highly conserved sugar molecule, very hygroscopic. It just really soaks in the fluid and forms a nice pasty-like layer. It is a critical molecule, one of the characteristics for the cartilage extra ECM. It has chondroprotective and chondrogenesis properties with an excellent record over many years. Yeah. So once into a 3D type of scaffold, it really looks like a cotton, a felt layer in the surgical hands. It's about 2 to 3 mm thick. Yeah, it's biocompatible, resorbable. And if the scaffold comes off and gets dissolved into the knee, it just becomes hyaluronic acid anyway, which is what we inject into such knees. So really very little side effects. And for me, I don't even order them specially. It's well stocked in the OT. Anytime I see a defect, I pull it out and I just paste it. Yeah, so it's quite easy. So it has both a structural role and a biologic role. Structurally, it traps, it's like a net. Yeah, it allows the cells to hang on to it, forming a 3D scaffold for the new layer to form. Biologically, it releases the hyaluronic acid and permits the formation of a hyaluronic acid-rich with chondrocytes environment. Yeah, it forms like a new layer. So this is the theory behind it. So this is how I do it. And we published this technique 2 years ago. So this was a 57-year-old male, as an example, persistent right knee pain after the classical twisting injury. Examination was unremarkable, very nice neutral alignment, and MRI shows medial meniscus tear, well, trichom arthritis, large full thickness defect. Mechanics are neutral, but large full thickness defect. Probable traumatic cause because of soccer over the weekend. So again, classically symptoms going up and down. Initially was better with conservative treatment, and then repeat MRI shows the same cartilage defect with chondral loss. Patient is still symptomatic. So what do we do? So at the time of scope, this is what I see, huge tracts of bone stripped of its cartilage. And clearly it's longitudinal. This is really where the patient, as he flexes and extends, scrapes and traumatizes the cartilage. Yeah. So what I do is I debride the edges. I clear away the unhealthy neighboring cartilage, and I go on to do a micro drill. Yeah, is what I've shared, that rather than just a microfracture, by drilling it a little bit deeper, I get more blood really from the marrow to come out. I can't prove it on my cell count, but it really looks like a BMAC. It's just a lot of bleeding there, which is great. Then what I do is, and when I apply the Hyalofast, the acellular patch, I use a simple duromo syringe. Through my portal, I size it. I make sure that the syringe comes in perpendicular to the surface of the bone. Yeah. Then I dry the entire knee scope to make it an air arteriogram with nicely spaced micro drill holes. As you begin to suck on it, you create a negative pressure. Blood will begin to come out. That's what we want to see. We want to see it bleeding. I then prepare the Hyalofast by cutting it to shape like this and stuffing it into the syringe. That's ready. Then I deliver the Hyalofast with an air arteriogram with very simple delivery. The Hyalofast layer is so hygroscopic that it really soaks up the blood. And if you find that whatever you apply is not enough, you literally can patch it up. As it melts, as it soaks up the blood, it melts to form one coherent layer over the defect. So that's why I call it match to patch. It's just patching it up. Yeah, and it's slowly, gently, without fluid and air arteriogram, to create that big layer. So the final review, you can see this blood-soaked layer hanging onto it. So this is a large one. This is relatively uncontained. Yeah, so it's a little bit worrying because it can easily, if you're not careful, it can slide off. What I do is I wait at least 10 minutes. As it melts, it becomes sticky. Yeah, and you must range the knee. Make sure it doesn't literally fall off before you. So this is the other example where I've learned from this example and others that age alone is not against this. So this is an elderly female in her 70s with one year history of pain. Giving way, again, right knee is quite neutral. For a 70-year-old, this x-ray is really quite good, actually, but she has medial joint line tenderness. The x-ray is quite all right, but on MRI, it shows a medial trochlear groove defect. Medial trochlear groove defect. So we go in, it's a small ulcer. We begin to debride the edges. And again, I start doing micro drill. Over the layer, I then dry it up. Yeah. And I apply the patch. It goes in very neatly. So in a small, well-contained defect, it really sits in nicely and just forms a nice layer. Yeah. So finally, that's what it looks like. So whether it's a large defect or a small one, the Hyalofast, as long as you really site it properly and give it time for the blood to soak in it, it's quite good. So over the years, we've developed this way of delivering it in a very simple, cost-effective using syringes. So in type 1 femoral condyle, it's for the weight-bearing zones. And I call it the type 1 where I just cut the syringe flat and it's applied just flat on. In type 2 is when I address the beveled edges, the edges of the femoral condyle. They're not strictly speaking non-weight bearing, they could be partial, and that's why I still have to address these. So these type, what I call type 2, I cut them at about 30 degrees, yeah, and they can really cater to the edges of the condyle. And then the type 3, where I cut to 45 degrees, this is really to address the femoral trochlea. So very simple modification of our syringe to deliver to most parts of the knee. So we then look at our outcomes, and again, we published this 2 years ago, clinical outcomes of our Hyalofast. This was one of our early examples, X-rays, and pre-op, you can see the cartilage defect. Then MRI, and I think 3 months or so, we can begin to see that layer. There's still a little bit of edema in the subchondral bone, but the cartilage layer is quite nice. Yeah, so that's neat. So when we look at our data, followed up for 2 years, those are, the age is about 47, not particularly young, but in their 40s with relatively okay BMI. Yeah. When we look at the distribution, most are at the medial femoral condyle, right in the middle part, the center. On the lateral femoral condyle, again, they're mainly in the center part. And on the trochlea, middle part, zone 2 had the highest number. So very consistent, very logical, central areas where the compression, where the articulation is highest. So statistics at 6 months. At 6 months, we see the IKDC scores going up from pre-op 33 to 54, and this continues to go up at 2 years. Yeah, so from pre-op IKDC, it goes up, and significantly so. So at the end of the 2-year follow-up from IKDC of 33, it goes up to 66. And that's really, really significant. And our patients really feel better. Our current study is that these are at the 4-year mark, and the scores continue to rise with a slight plateauing effect. But at least they don't drop, they don't disastrously fall, even though they're not, properly speaking, hyaline cartilage. We then plot them against BMI as well as against age. There is not, doesn't appear to be a cut-off level beyond which it does not work. And so we continue to add more numbers to these studies and see whether with a larger study, more data can come out. So when you compare other people's study, this was the original Hyalofast people, the Prof. Buddha and Giannini, who did the same. Yeah, in their case was Hyalofast soaked with BMAC. So they too showed continued improvement until up to 2 years. In their study, they also biopsied to show very much hyaline-like structures coming out. So in this technique alone, what I've introduced the idea of using an acellular patch. Very simple to use. Yeah, it's one-step acellular patch repair. The arthroscopic delivery is very easy, and 2-year results are really quite okay. Yeah, so as a solution for ulcers, I think it's one of the things that we can discuss and perhaps try to promote. So with that, thank you very much. And coming further on to what Dr. Raj was saying, indeed, this year I am hosting the academic congress of the Asian Shoulder and Elbow Associations in December 22. And this is the website, SOA, Singapore Orthopedic Association.org.sg. It's all there in all the program. And everybody's welcome to come to Singapore this December. So thank you very much, Dr. Raj.
Thank you, Tini. Just one question before we move on to your other talk. So this follow-up has been only clinical, or have you had a chance to look at all of them arthroscopically? to see what exactly is the status of your hyalofast patch?
All right. So most of our patients was clinical data. Some had MRI, yeah, which showed, in fact, about half of them had MRI, which showed a layer filling up there, although slightly thinner. One or two I had to rescope because of unrelated problems. And I found that the same pretty layer of healed cartilage. But have I biopsied them? No. So we've not had the opportunity to biopsy any of these.
Thank you. So now we'll go on to the other talk of arthroscopic cuff repair, augmented with autologous PRP.
Okay, so yeah, so from biologics in the knee, I'm trying to move to biologics in the shoulder, and we all have done cuff repairs. And let me share screen. Yeah. So the challenge I have is with an arthroscopic cuff repair, how do I improve healing? We have talked and indeed researched quite a lot about the suture configuration, the tears, how do I improve, tighten, and so forth. But how do I improve the biology of cuff repair? So that was my challenge. So when I look at the data with the literature, and yeah, this is really a bit more busy, but I'll just summarize it for you. I was looking at biology. Can I use PRP, platelet-rich plasma, for healing? And this meta-analysis, which came out 2 years ago, suggested that with PRP, no matter how it's delivered, seems to improve the outcomes, whether in tissue healing, lower rates of re-tear, and improvement of scores. So the presence of something biologic would trigger improved healing. So that's something I keep in mind. So the next question is, how do I do it? So this one, most of them, in fact, were using injection. So liquid PRP injections into the cuff repair. Now that's something I'm not quite agreeable to, because it means fluid in a fluid medium. It means that fluid will run all over the place, and there's the dilution effect. And that's why in later studies, the Koreans had to do repeat PRP injections, which is counterintuitive. You don't want it to be running around because it will cause more stickiness and healing. So I really want to use PRP, but I do not want it to be washed away. I do not want the dilution effect. I want to be able to concentrate PRP at the tendon bone junction where it is most critical, where healing takes place. So I begin to think about an arthroscopic cuff repair with an interposition PRP gel. What if I make the PRP in a gel? And what if I tuck it in as part of my repair? So in this talk, I wanted to share how I do it, the surgical technique. And because it's an ongoing study, I'm afraid I do not have the data at the moment yet. So this was our case, 62-year-old lady with a right shoulder pain, worsening pain, some degree of stiffness, and pain worse at night. Yeah. So, okay, we'll breeze through the physical examination. ROM, not too bad. Yeah. And then Job's test was positive. Hawkins' speeds was positive, and clearly her power was weakened. When I then, on the x-rays, really quite normal looking. But on the scan, it shows a tendinosis with a small bursal-sided partial thickness tear of the anterior fibers. So small tear there, and I thought, okay, this is one of the better ones that I can try to do. The next few slides, I'll show you how I prepare the gel. So what is different compared to the normal PRP injection is that we use 20 to 30 mils of blood, using it into two of the two tubes, the orange and the blue. As always, centrifuge them, and then I draw out the PRP as shown. This is the blue tube, and then the orange tube. And then we have calcium gluconate, and we aspirate and we put it into the dish as well. Now be careful at this stage, the PRP will quickly begin to gel up. So we then transfer into the medium, into the mold that we want it to gel in. And here I use the simple small cups, yeah, which over time, over 15, 20 minutes, it will gel up. And then remove them and cut them into small pieces. I needed a way to deliver it right at the tendon. So I used my trusted old syringe, cutting it in the same way as you saw me using for Hyalofast and applying the gel right over there. So that's ready, what I call the doorstep delivery. Okay, so let's go back into the shoulder. So here, I skipped the glenohumeral part. I'm not showing the slides. Here is in the subacromial space. I'm cleaning up the acromion as well as the supraspinatus tendon. So all the bursa and acromion is then removed. I then identify the tear, and yeah. So then I use a probe and I can see where the tear is, and visualizing it, I can see how the tears is both anterior and posterior part. Okay, the cannula is then inserted in. As you can see, it is ready to deliver anything right at the edge of the tear. So then I address the interior tear first. And the technique here is to use 2 sutures into 2 lateral rolls. So each tear has a single lateral roll technique. I pass 1 suture anteriorly and another suture posteriorly. Same with the posterior tear. I pass 1 suture anteriorly that will bring it in the middle of the 2 sutures and 1 more suture posteriorly. So 2 suture mattress sutures in a single lateral roll pattern. Yeah. So then what I do is, if you can see the picture right at the corner there, my syringe comes in between the sutures coming in. I then deliver the PRP gel, which is that yellowish mass that looks like a little bit like fats, but it's distinctly different color. And it is then inserted right at the tear, right at the hole. If you notice the 3 pictures, they are air arterial. So I switch off the water, I deliver the PRP gel. Once it's tucked into the tendon, I tighten the sutures, switch on the water again, and this is what we get. So you can see that, and I just use a simple McDowell, stuffing it in right at the tendon bone interface. Yeah, that is where it's critical, right at the tendon bone interface. And all along, I'm holding on to the sutures, so it prevents the sutures, the gel from flying away. Yeah, at the same time, then I quickly tighten the Versilock. Yeah, I hold it down, and then you get the final outcome. You have 2 of these very nicely bound lateral row anchors. And you can see the PRP gel, that yellowish layer, sticking right at the interface. So to me, that's what I want to do. I want to make my cuff repairs more biological. I want to tuck in a PRP gel right at the repair site. Yeah, so you think about it, it's concentrated where it's needed most. I don't need it flying around. So when I look at the literature, there was a technique that they used to describe using gels, but it's a rather complex technique where they cut into pieces as well, and they string it in like beads onto the sutures. So I'm not sure whether it's really concentrated at the healing junction or it's just along the sutures. But this is the other technique that was described. Yeah. But so far, we haven't found anyone that uses gel right at the tendon bone junction. So overall, with this technique, all the sutures are ready to be deployed, ready to anchor. And all I need to do is then deliver PRP gel right at the cuff repair. So I think this is a new way of looking at things, how we can deliver gels at the tendon bone junction, where it matters, where healing takes place. I don't suffer from the dilution of a liquid injection. And this delivery is really easy at the doorstep of the tear. So that's what I wanted to share, that really in this day and age, biologics and curve repair is probably what we are looking at. Yeah. So thank you once again, Raj, for permitting me to share this technique.
Thank you, Denny. That was really innovative. Ram, you have any comments on this?
Oh, yes. It's a very impressive technique, because I always thought when you do PRP injection after orthopedic surgery, it gets washed away.
Yeah,
So
Ram, that's
already
why I wanted to gel it, you know.
Yes, hemolysis, a fluid, arthroscopic pump, everything. My question is, do you, when you do a double row repair, would you like to have this PRP gel between the bone and the tendon after the medial row or tied, or what is the difference between you doing this for a single row as well as double row?
Yeah, so for double row, Ram, I'll show you another day. The technique will be the same. So I put in the middle row anchor, I pass it on. Then the key is just before we seal it off the lateral row. Yeah, then the tendon is already partially closed. No, then you just tuck it in before you seal off the lateral row. Yeah, because if we put it in too early in the liquid medium, the gel will fly away.
Yes.
So the actual insertion must be an air arteriogram. So everything is in liquid, everything ready.
It's a little bit difficult in shoulder, isn't it?
Yeah, that's what I did just now. You saw the pictures. Yeah. The pictures were all in the air arteriogram. Yeah. So actually on the outside, the sutures are ready in the anterolateral portal, and I had to create an accessory portal just for the syringe. So both, everything ready, sutures, everything ready, whether there's a medial row or not. Let's say we tie down already. Yeah? Then just before we seal off the lateral row, we deliver the syringe. We deliver the gel, then we lock it in. So that 1-2 timing has to be critical. So temporarily I shut the water, deliver the gel before it floats away, and then I lock it in, and then I run the fluid again. So it's that
timing is
1-2
crucial.
sequence.
Timing
yeah. Sometimes we may forget, and then we run the water early, and okay, let's restart.
Okay, thank you.
But then there is also one more question on the chat box. How long do we keep the patients non-weight bearing after hyalofast?
Okay,
and
great question.
Another question is, how is the hyalofast improved from microfracture and chondro type?
Okay. Okay. First of all, weight bearing, is it? Oh yeah.
How long do you keep the patient?
Yeah. How long do we keep the patient non-weight bearing after hyalofast? I keep them about 6 weeks, Dr. Pranav. Yeah. So during which time, depending on the location, if it is in the MFC, I do ROM. If it's in the trochlea, I do not do ROM. But weight bearing, non-weight bearing for about 6 weeks. Yeah. The more common ones are the MFC. So I keep them on passive ROM, but non-weight bearing for 6 weeks. After which is toe touch, partial, and then full weight bearing. Yeah. Hope that answered your question.
How is the hyalofast improved upon microfracture and chondro?
It's a great question. The thing is that with traditional microfracture, we compared to chondroguide. So compared to microfracture alone, we know that microfracture is a little bit like injecting PRP gel into PRP liquid. It kind of like floats all over. So the hyalofast acts like a net to help trap, whatever we microfracture, the cells and the proteins from the marrow. But chondroguide is very similar. Chondroguide has that same idea of having a layer. Yeah, so you can use chondroguide. These are nice options as well.
Denny, the hyalofast, you showed one literature saying hyalofast mixed with BMAC through hyaline cartilage. So is that because of the BMAC effect?
Probably, yeah.
So how do you decide where do you use only hyalofast, or you want a combination of BMAC?
Okay. In an ideal sense, the Italian study, they use BMAC. But for us, I find BMAC a little bit more expensive.
Yes.
So, and perhaps as a routine, I don't use BMAC, to be honest. So I just do good micro drilling, and I want to see a lot of blood. I seem to believe that that would probably be similar to BMAC, although it's not, strictly speaking, as rich as a BMAC cocktail. So I don't use BMAC routinely. So I never promised that it will be completely hyaline cartilage. But I believe that with a scaffold, it will be much better than just without anything there. You know what I mean? Yeah. And the nice thing is that as it dissolves, the hyaluronic it's very useful liquid anyway. It's hyaluronic acid, you know, so less of the downside. And if you balance that with the cost and the ease of delivery, it makes sense as a healthcare option.
Ease of delivery, your 3 ml syringe technique is amazing.
Yeah, it's so easy.
It can push it and it can punch it as well against.
Exactly. And, yeah.
How much cost is this one, Hyalofast?
How much does it cost? In Singapore, it's about 1,800 Sing dollars. Yeah. But here our Chondro guide is a little bit more. That's why. Yeah.
Thank you.
Most welcome.
I believe, is there another question?
Thank you, Danny.
Yeah.
That was absolutely fantastic.
Fantastic.
And I would like to thank again for your time.
Thank you
and
very
also
much.
Thank our Vice Chancellor and the Registrar of Tamil Nadu M.G.R Medical University for thinking of this program, for detailing this program. And I'm also quite excited that this might lead to a series of lectures where we can interact in the future on these topics. And I look forward to a timetable sort of arrangement so that everybody would know much ahead of what are the talks that are going to come. So I would like to thank again our Vice Chancellor and the Registrar of Tamil Nadu M.G.R Medical University for this. And thanks to all of you for joining. Thanks, Vijay, thanks, Sharon, and thank you, Danny. Thank you, Eric.
Thank you, Dr. Raj. Thanks, Ram.
Bye-bye.
Thank you all. Thank you for the kind invitation. See you around soon, Ram. See you all, Dr. Raj. Take care. Bye-bye.
Thank you.
Thank you, Vijaya ma'am.
Thank you very much. Very happy, and I will work with you all and Dr. Shekhar on the future programs as well, okay?
Yes, sir.
Thanks,
Yes.
Vice Chancellor, ma'am. Thank you so much.
Thank you, ma'am. See you.
Bye, bye, bye. Thank you.
Bye-bye. Thank you. Yeah.
Either answer.